Okay, so some of the things that were talked about earlier, we don't have the opportunity to achieve sometimes in children, in that we get what we get frequently when we do this scan, and to try and get a child to breathe in and breathe out, sometimes you press the go button at the time where they've immediately stopped screaming and they're taking in that big breath, and it just do that and hit it and hope that you actually get something that's reasonable. But cystic lung lesions in children, there's lots of different ways to look at them. And today, I just want you to recognize the spectrum of lung disorders. As has been said many times, both in adult and pediatric imaging, it's really important to have the clinical history to help guide you, as well as previous and follow-up imaging as well. So today, we're going to look at things that I've classified into these categories: congenital, acquired, systemic disease with pulmonary manifestations, and cyst-like lesions. So congenital lesions that we're going to talk about are the congenital pulmonary airway malformation, or CPAM, also known as CCAM, and sequestrations and bronchogenic cysts. There's been lots of discussion whether CPAMs and sequestrations are actually part of the same thing, just various different components, one showing more of one and the other. But I'm going to discuss them separately just to try and provide some clarity, but realize that there's overlap definitely in some of the presentations. So CPAMs or CCAMs are hematomatous malformations of the lung. They're usually unilateral and usually involve only one lobe. They're treated with surgical resection and they can regress. Sometimes we do monitor them, and when they're identified, frequently we follow them in the children initially, unless they're quite large and causing symptoms, until the child is old enough to be able to better tolerate surgery. And it's amazing how something that's so large at birth or even antenatally detected can become very subtle on follow-up. They can, however, become infected and have air fluid levels as any cyst within the lung parenchyma. And the differential diagnosis for CCAMs, depending on what you see them and how you're imaging them, is for lobar emphysema, CDH, large air cyst, and varying sizes of cysts. So let's have a look. So in this case, this is a term neonate that presented with respiratory distress, and this was antenatally diagnosed lung lesion. So it was known before. You can see a hyperinflated left lung with mediastinal shift. Maybe better on this one. So in this case, CT scan was done, and you can see that it's again what you get with pediatric imaging. If they're not intubated and you can't suspend the respiration, you kind of get what you get. And then you can see cysts of various sizes, mostly small, however, and this is using the Stocker classification, the type 2. Again, the cyst size can vary greatly between very small cysts, as in this case, or very large cysts, as in this case. And in this one, it's actually quite, you start to wonder what's going on exactly, because in looking at the X-ray, you just see a relatively large hyperlucent area with no air fluid levels or soft tissue component. And in this case, you can see that the cyst sizes are quite large, and the septa between them are very thin. And so it's almost imperceptible on the X-ray that was obtained. And these are the Stocker type 1 with the large cysts. This was a child that actually presented quite late, did not have antenatally detected findings, and initially was shown with this X-ray, a large cyst initially thought to be just a unilocular process, but on the lateral view, you can see better that there are actually multiple cysts with multiple air fluid levels in there. So rather than having a single cyst or an infected pneumonia, that this was actually a complicated CCAM. So pulmonary sequestration is the next structure that we not infrequently see. It's again a heterogeneous mass, can have solid or cystic components, and again may be associated with CPAM due to the overlap. It's non-functioning lung parenchyma, and it's due to abnormal accessory budding of the foregut. So again, back to embryology, everything in pediatrics kind of will go back to there for congenital abnormalities. There's typically no communication with the tracheobronchial tree, but they can be aerated due to collateral air drift. And the trick here is to try and find the systemic blood supply. It can be from a vessel on either side of the diaphragm, and but it's from a systemic blood supply. So it's important to look both above and below the diaphragm. And venous return may be via pulmonary or systemic veins or both. The intralobar type occurs earlier in development, usually in the posterior basal area, and the extralobar type we showed earlier in the suprarenal fossa. So this is an intralobar pulmonary sequestration, and you can see it looks quite similar to the images that I just showed you of the CPAM. But what makes it different? So in this case, the trick is then to try and assess the vascularity of this lesion. And that was done with CT scan enhancement and looking at MIPS and trying to follow. Now we had actually investigated this lesion with ultrasound initially, looking for the vascularity, and identified some vessels that were crossing the diaphragm. So had a good idea on how to try and investigate this with the CT scan. And again, you can see that the arterial supply is by a branch of the celiac axis. You can follow it here, coming off, and then going up into the lung parenchyma. And then you have the venous drainage via the pulmonary venous return. So in seeing that type of arrangement and in seeking it out actively, then you can differentiate this. And it makes a huge difference as to resection for the surgeon. If they don't realize that there are a couple of vessels that are crossing the diaphragm and infradiaphragmatic origin, then they're going to have a lot harder time in trying to obtain hemostasis in these patients. And we've had a few recently that have had near catastrophic bleeds, and that's a shame for a lesion that's otherwise fairly innocuous. Again, 3D displays are excellent, and these are amazing. We see them, our surgeons are fortunate to have PACS displays in the OR, and they can use these. We create them to help in surgical planning, and again, you can see both the arterial and the venous drainage to better effect here. Next is bronchogenic cysts. So again, with the embryology, it keeps coming back to embryology, so if you hated that, I'm sorry. Again, supernumerary budding of the ventral diverticulum of the foregut, and it's usually mediastinal subcarinal, but it can be anywhere. So it sort of depends when it originated, how far out it will be within the lung parenchyma. They're usually solid unilocular cysts, and they can have mucus or fluid content, and if they've been complicated, then they can have air within them too. They typically, however, do not have communication with the tracheobronchial tree unless there's been some complication. They're well demarcated, rounded, soft tissue density masses that can cause compression if they're large or in an appropriate area. And CT and MRI are really helpful in this to assess wall thickness and internal content, look for other abnormalities, and identify them as intraparenchymal from other situations. So in this case, there was a child that had this lesion, and I just told you that they don't normally have air within them, but this one did. And it was a known lesion that was diagnosed antenatally, but when he came in, he was febrile. So in this case, the bronchogenic cyst was complicated. You can see an air fluid level within it. And on CT scan, you can see this, the lesion to better effect and the air fluid level within it. So the round, solitary, fluid-filled lesion, relatively thin wall, even though it has had some complication. And the pertinent negative here is that there's no solid component or nodular wall, and that's going to become really important when we see another lesion later. So any lesion that you see that looks similar to this, that is, may or may not have communication, it's really important to assess the wall and look for lack of nodularity so that you would call it confidently a bronchogenic cyst. Now, let's talk a little bit about acquired cystic lung disease. Now, these things differ clearly in children from the adult population. We hope that most of our children are not smokers, but they do have other things called ventilation, prematurity, and they end up with damage to their lungs because of surfactant deficiency and high pressures used in ventilation. A lot of our lung disease population are neonates, and kind of in the first few years relate to preterm infants and the complications surrounding that. And there are some tumors that affect the lungs here as well, and infections and pneumatoceles we'll talk about. So pulmonary interstitial emphysema is a complication typically due to respiratory distress syndrome and ventilation-related disorders. Air dissects into the pulmonary interstitium and lymphatics because the alveoli are not very compliant. They reach a certain point because of the lack of surfactant, and then a small leak will be found, and then they'll dissect into the lung parenchyma. It's nearly always associated with positive pressure ventilation. And due to the reduced lung compliance and surfactant deficiency, low birth weight, all these things are risk factors for developing PIE. Now, they're not true cysts on pathologic evaluation, but they do appear cystic, so that's why they're included. So in NICU, the reported incidence is about 2 to 3%, but it increases in premature infants by 10 times that. So it's definitely significant, and it's something that can then progress later into bronchopulmonary dysplasia. It can resolve, it can persist, and some of our prenatal, our children that are born preterm end up on chronic ventilation requirements with oxygen or sometimes even with tracheostomy. It may affect one lobe, one lung, or be diffuse or bilateral, and there's no lobar predilection. And you can see here, this looks very similar to the other image that I showed. So the issue here with children imaging and trying to differentiate whether it's one disease or another really hinges on the clinical history, as we've said before. As well, if you have previous studies for comparison, that's even also very important. And in this case, you can see that it's only affecting one lung, it's hyperinflated, there's compression towards the other side. This is a child that is intubated. But the study that this child had earlier shows this, and again, it's a surfactant deficiency with diffuse ground glass and respiratory distress syndrome. So when you have that knowledge, you can be confident in making that diagnosis. Again, pulmonary interstitial emphysema can be bilateral. You see hyperexpanded lungs, and you can see this change over time. Now, the other thing to note is that the heart can get smaller and smaller with time because of increasing intrathoracic pressure and diminished venous return. And if it's a unilateral process, sometimes they'll selectively intubate the opposite side or administer surfactant and intubate the opposite side to give the other side a rest. So from that then leads, in some cases, to bronchopulmonary dysplasia. And this is a complex consequence of high oxygen and barotrauma to the lungs. So premature infants, again, most commonly, history of positive pressure ventilation, and frequently they've had at least some component of pulmonary interstitial emphysema. Again, the clinical history can be helpful, previous imaging helpful, and what you end up with is severely dysplastic parenchyma alternates with areas that are not so severely dysplastic, and they can progress onto fibrotic changes in the lung that can be chronic, or they can resolve somewhat with time. And again, you get this mosaic aeration pattern and the soap bubble appearance, which has been characteristically described. It has a preferential basal distribution, but that's not always the case. So in this image here, you see appearance of bronchopulmonary dysplasia with really thickened interstitium, really heterogeneous, disorganized appearance to both lungs. In this case, it's worse on the left base than the right. And again, a very flat diaphragm due to the hyperinflation. And the issue with this then is because the diaphragm has nowhere to go, there's very little aeration, and you see these children have inspiratory stridor and abdominal breathing and lots of different ways to try and aerate. Again, on CT scan here, we see some thick interlobular septa, bands of fibrosis, cyst-like spaces, and a preferential basal distribution. So just the same thing that we're seeing on X-ray, but to better effect. And we don't typically image these children with CT scan. If they have a history, if they have appropriate kind of clinical context, then CT imaging really is not indicated in that case. Again, just coronal images demonstrating the same thing, and you can see these bands of fibrosis and the preferential basal distribution on the coronal, more so than on the axial images. Next, we come to infectious diseases. Now, pneumotoceles are cysts that present acutely or subacutely, and they persist until the infection is treated. They can be from bacterial infection or other infection, and they're the result of necrotic lung tissue communicating with the airway, or interstitial air tracking and interstitial air cysts. So in bacterial, let's just talk about that for a second. Lung abscesses are most commonly caused by strep pneumonia in the pediatric population. They can be gram-negative anaerobic or staph, and Klebsiella is also a common bacterial infection in our pediatric population that we see as a cause. These ones are typically upper lobe in location. So in this case, we see a child that has an area of consolidation that's evolving right here, more so in the left lung than the right, but again, some ground glass opacification here. And then over time, you can see that now formed more of a rounded area of consolidation with an air fluid level in it in the area of previous lung consolidation. And this child also has a large associated left pleural effusion or empyema. So when you have the history of previous area of consolidation evolving to an area of air fluid level and rounded appearance of pneumonia, you can be confident that this is a cavity or lung necrosis / abscess related to previous infection. If you saw that de novo, you wouldn't know whether or not there was an underlying predisposition with a congenital pulmonary airway malformation. And you can see in this child follow-up post-treatment that there's actually no residual cavitary lesion once they've been actively treated for their infection. Another disease that's commonly associated with cystic changes in the lung is TB. We do have certainly a population within the Greater Toronto area, and our northern populations are fairly isolated. So once TB ends up in that community, it goes fairly rampant through the community as well. Primary TB, we all know the classic findings: ipsilateral hilar or mediastinal adenopathy and a small lung focus. And these can cavitate over time from liquefaction and necrosis, and they have a pretty characteristic appearance. It's also helpful if you have the history. And in this case, the typical upper lobe fibronodular infiltrates and the cavitary lesion in the left upper lobe seen to better effect here on this CT scan. And again, you have your area of cavitation, thick-walled, a little bit shaggy, and air fluid levels. So in this case, it's pretty evident that TB was the cause. Fungal infections don't typically happen in a well population, but in our community, certainly of hospitalized patients, of patients that are immunocompromised with bone marrow transplant, leukemics, other immune suppression for various disorders, then infectious disease presenting with fungal infection of the chest is a very common finding. And the manifestation can be varied depending on what form they have, whether it's invasive aspergillosis or so on. So again, you just need to know the background history of the patient to make a relative and reasonable diagnosis. Focal alveolar opacities may transform into thin lesions, thick lesions, so it's just a matter of serial ultrasound. And certainly in our patient population, we do high-resolution CT initially, and in follow-up of our at-risk patients who are undergoing treatment. And you can see here that the upper two images, we have a lesion with a nodule with some halo around it, and then over time, even though they were treated, progressed to cavitation centrally. So that's certainly a common appearance, and you may see various different types at different stages of progression. As you can see in the left lung, there's another nodule that has not cavitated. So seeing them at different stages is certainly common. Pulmonary malignancy, thankfully, is not terribly common in the patient population. And the primary pulmonary malignancy is pleuropulmonary blastoma. And even though this is fairly unusual and we don't see it too often, I want to talk about it because, again, it's something if you think about, then you'll hopefully do better than we did with the patient I'm going to present. Lymphoma, it can also cavitate and necrose, forming lung lesions, and you can, as well as in adults, get hematogenous spread of metastases that can also necrose and cavitate. So pleuropulmonary blastoma is a great mimicker of a lot of other diseases. It's an embryonal tumor of the lung. It's a malignant primary neoplasm, and it's got combined solid and cystic elements, and that's where this comes in important. It's frequently misdiagnosed as a CCAM or CPAM, a nonspecific lung cyst, and most children are under the age of 6 years. So if you have a child under the age of 6 years and you've got a funny-looking lesion, put it at least in your thought process and then get rid of it if it doesn't apply. The reason being is that it's usually 18 months from the time of initial observation to the time of correct diagnosis, and that can be very devastating in a child. And because of this, there's significant morbidity due to delayed diagnosis. So this was a 7-month-old girl who presented to the emergency department with febrile illness, and she was diagnosed with round pneumonia. Common things being common, that makes perfect sense. You see this lesion there, looks pretty well defined, and she was sent home. Well, the symptoms and the lesion persisted, and then a CT was obtained at an outside center and was sent in for review. And unfortunately, the study was done in a way that we didn't have all the images. It was kind of every other one that had been sent in. And it was diagnosed as a cavitary lesion, thick irregular wall, probably a superinfected pre-existing lesion versus a Pneumatocele post-infection with fungal because of the halo around it. And the thing that was missed at the time was the fact that the wall posteriorly is quite abnormal. It's thick and it's enhancing and it's irregular. And that was different from the adjacent lung parenchyma. Now, certainly in this location, some adjacent compressive atelectasis or consolidation in that region might also have that appearance. But unfortunately, there were some issues with follow-up. The family was not too keen on imaging or actually health care at all. And the child was lost to follow-up, missed the CT appointment, and came back like this. So 4 months later, you see this massive solid component, and the typical rim of air around the lesion was due to some necrosis of the tumor. So because of the patient compliance factors, we missed the boat on this one, and you can see that it's a very large tumor, and the patient ended up succumbing due to this diagnosis shortly thereafter. So it looks like a lot of things. It can be easily missed, and so just have that in the back of your mind. Certainly, most things will be round pneumonia that look like round pneumonia, but think about it. Lymphoma can cavitate, both children and adults. It's not something that's unusual to see, but just to recognize it for what it is rather than a secondary pneumonia. You can see this irregularly cavitating lesion. Non-Hodgkin's lymphoma is the most likely one that cavitates, and it's thick-walled, usually in upper lobe, and that may be due to rapid response to chemotherapy and central necrosis related to that. And again, here you can see the CT scan that demonstrates the lymphoma mass with internal cystic change. Oops. So other systemic or syndromic diseases that present with a cystic lung component are Marfan syndrome, Langerhans cell histiocytosis, and cystic fibrosis. And here this is kind of an overlap because it could be within the airway rather than within the lung parenchyma itself. So let's talk about Marfan syndrome. So it's a connective tissue disorder, affects musculoskeletal, ocular, cardiovascular system primarily, and the pulmonary involvement is not so typical, but it is something that we look for. They come in and if you see a tall or lanky child, and then they present with acute chest pain, and they find these bullae and cysts. They can be confluent and leading to honeycomb changes with the lung, and the peripherally located bullae can lead to pneumothorax. So in this case, this was a child that came in with an acute chest pain and difficulty breathing, and you can see on this magged up view that there's the a bullae that's at least left, and the rim of the pleura, so a fairly sizable pneumothorax in this child. The child went on to CT scan just to have a look and see what else was there, because sometimes we'll do, surgeons, if they have a predisposition or have had multiple pneumothoraces, may do an apical stapling and kind of resect that area. So here you can actually see that there are bilateral apical bullae in this child with Marfan's, and this might be a child, if they've had recurrent pneumothoraces, would be amenable to bilateral apical stapling. Again, this is a different child with Marfan syndrome, and you can see multiple areas of hyperlucency in both lungs with no general predilection. Bilateral emphysematous changes. And another one that we talked about, it presents a little differently in children with Langerhans cell histiocytosis, eosinophilic granuloma, another name for it. And it has infiltration and proliferation of large histiocytes. Pulmonary involvement, again, is quite rare, but we do see it. So if you see a funny-looking chest x-ray and it hasn't, in a child that may have failure to thrive or is otherwise unwell, certainly something to think about. Combination of diffuse air-filled cavities, varying sizes, and they may become confluent and result in a honeycombed appearance. So here you have a child with systemic Langerhans cell histiocytosis, looks very disorganized on this chest x-ray. You'd wonder if they had some sort of pre-existing condition or bronchopulmonary dysplasia, looks very abnormal. The appearance is diffusely throughout the lungs, so in this case it was thought not to represent a cystic fibrosis, but we have a population of patients that are not diagnosed for cystic fibrosis until much later in life. In this case, we can see that all lobes are affected with no predilection, varying sizes of cysts all throughout the lung parenchyma. And the giveaway in this child was on the skeletal survey, where you can see the characteristic lytic lesions within the bones. Here you can see one in the proximal femur with the endoschial scalloping, the ones in the skull. This one was particularly subtle. Certainly if you don't window it correctly, you might not see it. And they may not be diffusely throughout the skeleton, but certainly you should look for them. So systemic disorders, including cystic fibrosis, are another typically pediatric lung disease, although with current treatments, lung transplants, patients with cystic fibrosis are living a lot longer and are then becoming adult patients now. But previously it was almost exclusively a pediatric problem. The lung manifestations are due to recurrent infections, inflammation, and fibrosis, and traction bronchiectasis with cicatrization of the lung parenchyma, opening those bronchi and distorting them. The thing, too, though, is that no different than anyone else, recurrent infection can lead to cavitation and abscess similar to any other patient, but their ability to clear is impaired. So in this case with cystic fibrosis, you can see the saccular and tubular bronchiectasis, wall thickening secondary to inflammation, but you also see that there is a lesion more inferiorly where there is a lung cyst formed from infection. Again, cystic bronchiectasis, again, the air fluid level medially. So various different appearances depending on how long, how severe, and how many bouts of infection they've had, or how well they're compliant with their medications. Certainly in a teenage population, that's something that we also find. So what are the cyst-like lesions and mimics? Well, cystic fibrosis would be one that we've kind of discussed because of the saccular dilatation of the airways. Congenital Lobar Emphysema, congenital diaphragmatic hernia, and loculated pneumothoraces and pleural disease can mimic lung cysts. Congenital lobar emphysema is, again, not truly cystic. It's usually confined to one lung, and what you see is attenuation of the vascular structures with hyperlucent appearance. It's due to partial airway obstruction, such as regional cartilage deficiency with collapse and air trapping and expiration, shift of the lung across the midline, and compression of the adjacent lung parenchyma with subsequent depression of the diaphragm as well as the lung expands further. And again, you have this typical appearance, and this is a presentation at birth. You would wonder whether or not if this child potentially had been premature and only received surfactant to one side and hyperinflation or intubation of the left lung, but this was just a child on room air at birth. And again, these are often seen or diagnosed prenatally as due to the fluid within the lung at that time. Again, what you see is attenuation of the structures with overall hyperlucency. No true cyst, though. In this case, it's just overall hyperinflation. At 22 months follow-up, you can see that there's relative paucity of bronchovascular markings in the left side compared to the right, but certainly less overall volume compared to previous. And they do frequently undergo enough involution that they don't need to have something done. However, in some cases, the overexpansion can be so severe that treatment does need to be initiated with lobectomy if it's causing issues otherwise with ventilation or vascular return. Congenital diaphragmatic hernia is another mimicker. Sometimes you have a slam dunk with these. 90% are on the left side, 90% unilateral. They can cause pulmonary hyperplasia due to both the side into which they herniate as well as the opposite side due to compression. And the key here is to look for the diaphragmatic margin. Again, most of these are diagnosed antenatally, so you have a good idea before what you're dealing with. However, in this case, it can be hard to tell if you didn't have prenatal imaging what exactly was going on. There's a child with respiratory distress, lots of cystic spaces, and the left diaphragmatic margin here looks almost continuous, but it looks a little funny in that it's is lobulated and a bit weird in that regard. This was a child then that underwent ultrasound. We love ultrasound for everything. So, and you can see here that ultrasound shows the diaphragmatic rent and the tissues actually extending from the abdominal cavity into the thoracic cavity. And the calipers don't show the diaphragmatic defect. And in this case, we actually do have a good relationship with our surgeons. Sometimes they will ask us what's in the chest, what's in the abdomen, how large the defect is, and they can plan things differently, whether they're going to use a patch for closure. So certainly this can be something that helps. This one's a gimme. When you can actually see the bowel going from the abdomen all the way into the chest, you don't have to think too hard to come up with that. But again, children... And it's right-sided as opposed to left-sided. So the herniated bowel, as I said yesterday, again, because it's not fixed to the mesentery, is at risk of volvulus intorsion and bands and adhesions and all kinds of different things. So again, there's lots of different variables to consider, not only at the time of repair, but subsequently as the child ages. Loculated pneumothorax, air just in the pleural space. Again, it can mimic abnormalities within the lung parenchyma. And again, cross-sectional imaging can be helpful. Empyema as well with bronchopulmonary fistula can look like lung cysts too. And again, this is just a loculated pneumothorax inferiorly in a child, obviously, that has had some barotrauma. And in this case, it was just due to a bad asthmatic that subsequently ended up with infection. Again, you can see, though, that there's also a mediastinal gas pretty much everywhere. In this case, it wasn't a lung cyst. So in summary, imaging provides lots of detailed features for assessment and differentiation of cystic lesions and complications presenting in kids. But what you really need is the adjunct of clinical history to help differentiate them. And as well, previous and follow-up imaging can help you differentiate the lesions for overall better patient care. Thank you.